I'd like to thank you all for being here. My name is Maria Ludwig, and I'm one of the Associate Directors at the Louisiana Public Health Institute. And we are very pleased to be convening this session on interpregnancy care. This is a learning community series that we are going to be providing to you all over the course of the next 12 months. And this is just the beginning to give you a taste of what's in store. We're very, very pleased to see everyone who range from community health centers to payers to our state partners and our city partners and the hospital system and teaching hospitals. We are very, very pleased to have you all here. We have received funding from the Baptist Community Ministries, and I'll give Liz Shear an opportunity to speak in a little bit to sponsor this. As you know, and you're going to hear more about today, interpregnancy care is a new buzz word around trying to improve the health of the mother postpartum and in between the times that she's having care. So you're going to hear, or having children. So it's interpregnancy care, or some people call it interconception care, and you're going to hear more about that. That's what today's devoted to, and this whole series. We are bringing to you national, state, and local subject matter experts over the course of this series so that you are really learning the evidence-based and best practice. And as well, working within your health centers or within your environments, either you be a payer or a hospital, on how what your contributions are going to be to really improving the birth outcomes of women in New Orleans. We are looking at this as a pilot, and we are intending to make this a model program. So we really are going to be looking for what your experiences are with this curriculum, as we do want to produce a manual at the end that we can share with other communities that have difficulty with birth outcomes. We are building off of a model of quality improvement that we initiated under the Crescent City Beacon program. I'm not sure everybody here is familiar with that, but in the Crescent City Beacon Community Program, we focused on a quality improvement program over 3 years since 2010, and really looked at the way the community health centers were providing care within their walls, how they were managing their diabetic patients, as well as their cardiovascular disease patients, and really deep diving into the elements of chronic care management with a very intensive learning collaborative that we facilitated in collaboration with our partners during this session, or during this series, which is the Primary Care Development Corporation. We also launched during that program a health information exchange, which some of you may or may not know, called the Greater New Orleans Health Information Exchange, which in real time is letting the community health centers know when their patients have hit the emergency department or inpatient. So an alert is sent directly into their EMRs. And as a result of that, we are hoping to leverage that technology for this project so that women transitioning postpartum will be able to be linked very quickly into the primary care network. I'd like to thank the people who are here today, Dr. Rebecca Gee, who's the State Medicaid Director, Michelle Aletto from the State's Office of Public Health, our other state representatives that are here, the Primary Care Development Corporation staff, Carla Silverman, Alina Yurova, Sarah Blust, Kimberly Marabella, who are our partners in this learning community, Ann Dunlop, who's our nationally recognized expert and consultant on this project, who was the medical director for the Grady Health System, which is the evidence behind what this curriculum that we're delivering to you all, as well as Liz Shear, the VP of Baptist Community Ministries. And I'm going to let Liz say a few words.
It is a sincere privilege as a health funder to be able to leverage the hard work, intelligence, great ideas, evidence-based programs into a community. And I really see each and every one of you as a pioneer today. And your success is extremely important to BCM, to our board. My whole reputation is standing on your success here. What can I say? I'm charged. But really, as a health funder, you look at the landscape of all of the problems that we have, and preterm births are so tragic, and they're so, in many cases, so preventable, and they're so costly to Louisiana. I did not realize until I gained a little more insight into this whole maternal child health realm. I knew our stats were bad, but I did not realize really how dismal we were in maternal child health outcomes. And in a state where 70% of all of the births are Medicaid insured, there is tremendous opportunity to improve our preterm rate, reduce our infant mortality rate. And so for all of the hard work, creative efforts, expert process improvement leveraging work of Dr. Ann Dunlop, who has just been an outstanding pioneer, I am grateful. And I really am expecting to come back at the 4th learning session here and to hear about your individual success as you really morph. To me, we are in a historic period, and we're recognizing that the old model of just pure clinical primary care has got to yield to a blended model as you become a medical home, and the incorporation of social services and a much, much broader view of health for these women is so essential. So I salute you for your courage. I expect great results, and I can't wait to hear the 4th meeting.
Thanks, Liz. I'd like to thank our team formally, David Kullick, Jasmine Ventranza, and Alex Preeb and Jana Knight, who've been working on this project, really making a lot of headway. And then I'd like to turn it over to Carla. Thank you.
Okay. Welcome, everybody. Thank you, Maria. Thank you, Liz. Just to echo Maria and Liz, I'm so excited. We are so excited to have you all here. This is a really fantastic turnout, and I know, because I know I know the types of people who are in the room, that there's incredible expertise and knowledge sitting in this room, and I really think we can do amazing things together. So I hope in 3 hours, once this session is done, you feel excited, and you look forward to working over the next year on improving birth outcomes for the women of Louisiana and improving the type of care that women are receiving. Just to introduce us briefly, we're from Primary Care Development Corporation. Some of you know us because you worked with us on the Beacon Project, but for those of you who don't know us, we're a not-for-profit healthcare consulting firm. We're from New York City, but we work all over the country. And our mission is to improve the delivery of primary care in medically underserved areas. My background is as a nurse and a nurse midwife, so this project is really right up my alley, and I spent about 10 years delivering prenatal care, family planning services, and primary care in underserved neighborhoods in New York City, in the South Bronx and Washington Heights. So I'm very familiar with the issues that we're going to be talking about in a very personal and direct way. I also was the clinical director at Planned Parenthood Hudson Peconic, which is the Westchester, Long Island branch. I have some public affairs advocacy background work as well, so I couldn't be more excited to work on this. I have a great team. I have Sarah Blust, who's in the back. Her background is as a social worker and in public health. She spent a lot of her time before coming to PCDC working on programs that integrate women's health and behavioral health. I have Alina Yurova, who's here, who also has a public health background and a market research background. And we have Kimberly Mirabella, who's our admin extraordinaire. We couldn't do anything without her, so we're really excited to be here. Thank you. Just to let you know, in case you didn't notice, there's a camera there. This session is being filmed, just so you're all aware, but it's used for educational purposes only. So let's get started. If I could use the clicker, that would be really good. Okay. So I wanted to start with this quote, and it's from an expert in the field. His name is Milton Kudelchuk. He works at Harvard, and he says, in the future, interconception care will seem as normal and important as prenatal care is today. So I hope that you all will feel that way, if not by the end of today, by the end of the year. So I want to sort of step back and give you big picture, and then Michelle Alito and Ann Dunlop are going to focus in more on specifics. But in terms of the United States and infant mortality, we rank 23rd in terms of developed countries. Infant mortality is a measure of how many children make it to their first birthday. 70% of the infant mortality rate has to do with neonatal mortality, which means babies that make it to 28 days post-delivery. So, Louisiana doesn't do well in this area, but in case you thought it was just Louisiana, it's not. The country doesn't do well as a whole compared to other countries that have as many resources as we do. In particular, infant mortality is a striking issue for African American communities, Hispanic, and Native American. There are wide disparities. Predictors of infant mortality really hinge a lot on low birth weight and very low birth weight infants. Low birth weight is considered less than 5.5 pounds at delivery. Very low birth weight is less than 3.3 pounds. And while we are making, believe it or not, some inroads on infant mortality, in the last 10 years, we've made no inroads on low birth weight and very low birth weight deliveries. None, no improvement. So most experts in the field believe that reducing low birth weight is possible and that low birth weight is preventable. But it's a complex issue. There aren't any simple, straightforward solutions. And a lot of this is related to the fact that low birth weight is tied to health and social problems related to the mom. Most effective programs combine provision of healthcare services, health education, improvement in the community and the environment that these women live in, offering of community service and access to community services, and changes in public policy. Again, to step back and just place you in the bigger context, these kind of programs that are focusing on delivery of interpregnancy care, preconception care, and focusing on reducing infant mortality and low birth weight are happening all over the country and on a national scale. There's the HRSA COIN initiative. The ACA now has language in it that says that preconception care and interpregnancy visits must be covered. There are new QI programs that are actually tracking how many women actually make it to their 6-week postpartum visit. There are new HEDIS measures around that. And I think we know traditionally that a lot of women don't make it to that 6-week postpartum visit and are lost to care at that point. The CDC had a national summit on preconception care, and they have guidelines related to best practice in preconception care. And you actually have in your packet the website where you can go and check those guidelines out. And there are multiple Healthy Start initiatives. So I just want to put a question out to you, and you'll notice today as we go along, we're gonna have you be active. Could someone tell me what they think interpregnancy care is? Don't be shy. Yes. Right. Right, exactly. Thank you. So interpregnancy care is care before or between pregnancies for the woman. Traditionally, in our old model, in most models, right, a woman is pregnant, she gets prenatal care, she has the baby, maybe she comes for her 6-week visit, and that's it. Her insurance cuts off, her care cuts off, follow-up cuts off, and the next time you see her is when she's pregnant again, right? So there's this huge window of time where her health maybe could be improved, where we lose her. Interpregnancy care should address the continuity of maternal risk from one pregnancy to the next. And sometimes, as was mentioned, it's thought of as a subset of preconception care. So what kind of services do you think would be good to provide as a part of interpregnancy care? You can just call it out. Birth control. What was it? Dental services. Nutritional services. Psychosocial support. You did it. Chronic disease management, STI screening and treatment. Absolutely. Anything else? Education. Vitamin supplements. Okay, postpartum doula and childcare. Great. Oh, what was it? Parenting skills. Love it. Great. Okay. Mental, yeah, she said psychosocial, mental health, screening, treatment, all of that. Yes. Substance abuse. Yes. All right, you guys get an A. So, you know, the concept here, it seems like you guys understand it, is that to improve birth outcomes, we need to start before the woman is pregnant. For those of you who are prenatal providers in the room, you know that once a woman is pregnant, there are many things you can no longer do, right? You're pregnant, you weigh 250 pounds, kind of hard to really go on a serious diet to reduce your risk of diabetes and hypertension once you're pregnant. You want to start that before you're pregnant. You have hypertension, there's certain medication you can't take in pregnancy. Suddenly your options are limited. Maybe you have mental illness or substance abuse issues. It's complicated and challenging to try to start addressing those on top of the fact that you're pregnant and sick and have all sorts of issues going on. So if we can get to women before they are pregnant, we have this amazing opportunity to really improve their situation when they are pregnant. But that means they have to be talking to a provider and getting services before that positive pregnancy test. So I'll put it out to you guys. Why do you think interpregnancy care is not the norm? What are some issues? Money. And maybe more specific about money? Like no insurance coverage, or they lose their insurance, they can't pay for services. Other issues? Sorry, not culturally, you mean in terms of we don't provide culturally competent care? So does that mean women aren't going to come in for that care? Okay. Other thoughts? Yes, this is a great point. It's not part of the culture, right? How many of you have insurance, have access to care, have kids, and went to a preconception visit? I'm going to guess probably none of you. I have 2 kids, I'm a midwife, I never went to a preconception visit, right? So it's not in our culture, whether you have insurance or non-insurance, it's like, what's that, a preconception visit? And it's not in the culture of providers or healthcare providers, right? They understand the concept, but they're not used to doing that. And it might not be reimbursed. So, right, barriers. Women can't pay for the services, patients don't know about it. Sometimes you can't bill for it. Clinicians are not used to providing it. And I think for our patient population that we're talking about it, I mean, women are overwhelmed with other stresses. Poverty is stressful, and there are other issues that are at the top of their list, and things like taking care of yourself when you're not actually pregnant kind of falls to the bottom, right? If you need a job or a place to live, or your boyfriend's beating up on you, or whatever's going on. So, the New Orleans IPC project. Why are you here? What are we doing? I just want to put out there that this is a very ambitious project. We're trying to take on the challenge of every woman, every time for women of reproductive age. And what we mean by that is that we want to teach you to work together and develop processes in your centers so that you can not necessarily be waiting for the hospital to refer that woman who had an adverse birth outcome to you. I mean, we hope we can put that in place as well. But we want you to be able to identify those women when they're in your center, so that then you know this is a high-risk woman. We need to get her set up for these services. We're going to adapt the Grady model from that they used in Atlanta. We're going to have to adapt it for this community and for the way services are delivered here. And we need your help in doing that. I know I need to move along here. So you can read this in your packet, but we're going to teach you to screen and identify at-risk women. We're going to help you figure out, can you be providers of the IPC care package, or are you going to be people who are going to refer to centers that can provide that care? And then we're going to teach you how to follow up with these identified women and make sure they're getting the care and the services that they need. And we're going to talk a lot more about that later today. So today, goals for today's session. We want you to leave here understanding the details about the Grady model. What is it? How does it work? Why? What were the outcomes in Atlanta? And Anne's going to talk about that more later. We want to lay out the goals of this project and the related processes that we would like to work on with you. And really, we want you to meet other organizations. We want you to get to know each other and understand everyone who's providing women's health and IPC care services. So, quick overview. There are 3 more learning sessions after today. This is a learning collaborative. In January, we'll be talking about reproductive health services and family planning. In April, we'll be talking about behavioral health and social support. And in July, we'll be talking about chronic disease management and health promotion. We hope to see all of you at these sessions. There also, as part of this project, you will be provided 12 technical assistance calls. These are calls where we welcome your input about what you would like covered, issues that are challenging in terms of providing interpregnancy care where you work, so that we can bring experts in and discuss these issues. We'll also be helping with some of the processes that you'll be working on at your organization. The first TA call is October 3rd at 3 p.m. It's the first Thursday of every month. You'll be getting more information about that. Okay, lastly, if you haven't been to a PCDC learning session before, there are no wrong questions. We want you to be creative. We want this to be a time where you're outside of your normal environment, where you can brainstorm. We really, truly believe that you have the answers. We're just really here to facilitate and bring those answers out and put them together. And if there's something we're not thinking of, please let us know. So lastly, if you can put your cell phones on vibrate, that would be great. Bathrooms are just right outside the hall behind David. There are pipe cleaners on the table. Again, this is a PCDC thing. They're there for you to play with, make art, design, be creative, use your hands. We believe if your hands are moving, then your thoughts in your brain are moving. There are index cards on your table if you want to write questions, if there's not a time to raise your hand, and there's a box in the back. Please drop those questions in there, and we will try to respond to them during the session. Okay, sorry I ran over. Sarah is going to introduce our icebreaker activity, and yeah, welcome, thanks.
Morning. So you'll